Добре, дуже дякую. І так, ми починаємо наш ефір. Сьогодні з нами немає професора Фегерта, але я знаю, що він за нас хвилюється, бо він мені про це писав. І немає пані Оксани Збітнєвої, в якої нема світла, і вона також писала і вибачається, бо нема в неї зовсім світла. Ви знаєте, що ситуація зараз дуже складна. Тому ми дуже дякуємо всім, хто до нас приєднався. І в нас буде сьогодні дуже цікава тема – це розлади настрою. Ті, хто до нас зазвичай приєднується, знають, що ви знаходитесь в серії ефірів, яку ми проводимо разом з ЕСКАП, Європейською асоціацією дитячої та підліткової психіатрії, і де лідуючі професори з країн Європейського Союзу погодились в свій вільний час абсолютно безоплатно працювати для лікарів і медичних сестер в Україні, за що ми їм страшенно вдячні. Наша сьогоднішня спікерка – це пані Манон Хілігерс, професорка дитячої та підліткової психіатрії, керівниця відділення дитячої та підліткової психіатрії і психології Erasmus MC Роттердам, Нідерланди. Про спікерку нашу. У фокусі наукової та клінічної роботи професорки Манон Хілігерс розлади настрою дітей і підлітків, ранній фактор ризику та міжпоколінні впливи, що формують довготривалі траєкторії психічного здоров'я. Вона має значний досвід у проведенні поздовжніх досліджень у педіатричних популяціях і є головною дослідницею великого когортного дослідження Generation R, а також співголовною дослідницею проєкту Mood and Resilience in Offspring. Ми дуже дякуємо нашій спікерці і дуже дякуємо професору Йоргу Фегерту за допомогу в організації нашої серії вебінарів. Ми будемо діяти як завжди. Тобто ми спочатку слухаємо нашу спікерку, а потім ви будете задавати питання, які я буду зачитувати. Тому пишіть, будь ласка, ваші питання в коментарях в Zoom або в коментарях в YouTube, або в коментарях в Фейсбуці, в залежності від того, де саме ви дивитесь цей ефір. Коли ви пишете питання, будь ласка, представляйтесь, бо для нас дуже важливо, хто нас дивиться. Ті, хто дивиться цей ефір, він зараз буде йти в перекладі, або якщо ви дивитесь в Zoom, ви можете дивитись його в оригіналі. Запис буде також доступний як в перекладі, так і в оригіналі на каналі доктор Булавінова YouTube. Всім дуже дякуємо, що ви до нас приєднались в цей дуже морозний, дуже холодний і для багатьох тотально темний вечір, бо в багатьох працюють тільки бекап-системи, бо нема наразі електрики. Ми вам дуже дякуємо за цю увагу і просимо нашу спікерку Манон Хілігерс до слова. Прошу вивести спікеркою презентацію на екран.
Thank you very much. I hope everybody can see my presentation and hear me very well. Also, thank you very much that I am able to join this presentation series supported by ESCAP. I feel very honored to support my colleagues in Ukraine. Tonight, I'm going to talk to you about mood disorders, and I hope that I can give you some more information on these topics, not only from the major depressive perspective, but also from bipolar disorder. So, as said, major depressive disorder and bipolar disorder, I want to start with giving you some historical perspective and on the epidemiology and etiology of mood disorders. Then I will continue with some information about the DSM-5 classifications. I will focus more on the diagnostic evaluation and on differential diagnosis and comorbidities that are often present in these mood disorders. And I will continue with giving you an overview of current treatment according to guidelines on the psychological, but also on a pharmacological perspective. So let's start with the historical perspective and some facts and figures. I think it's important to consider that before the 1960s, the idea of a true major depression in children was actually widely rejected by child psychiatry. It was thought that only depression was present in adults. It was until the 1960s, 1970s that there was a turning point in this vision. And it was seen that in scientific studies that children do experience persistent sadness and other symptoms of depression, and even suicidal ideation. Also, what we saw is that there are the symptoms and the whole syndrome of depression is clinically similar to the adult depression. Although there are some different positions regarding how they act out regarding irritability. And in the 1918, in the DSM-3, that was the first official recognition of depression, major depressive disorder in children. And it was seen that in the DSM-3, the structure, the diagnostic structure criteria were also applicable across the lifespan. So not only in adults, but also in youth. So what is important, I think, is in this figure, as you can see with many, many colors, in purple, you can see that the mental disorders are depicted. And they are surrounded by many somatic diseases. But the mental disorders in purple often have their origin in the very early stages of life. And it is important to know because if we look at the different age groups, for instance, between the 5 and 14 years old, already depressive disorders are mentioned, including also anxiety disorders. And this is the same for boys and girls. Well, if you go to a later stage, an age group of 15 to 24, or even 25 to 44, you can see that especially in girls, anxiety disorders and depressive disorder and bipolar affective disorder are very prominent. And they are increasingly more prevalent in girls than in boys. But this is really the age of onset of these mood disorders. So regarding mental health disorders, what we know, and these are figures from the WHO, that 1 in 7 of 10 to 19-year-olds do experience a mental disorder. And it's not something that is very easily to live with. If you look at the global burden of disease, these mood disorders and mental disorders do account for 15% of this global burden of disease. Also, what we know is that depression, anxiety are among the leading causes of illness and disability among adolescents and young adults. And suicide is the third leading cause of death. And that's really important because it is often overseen that this is really such an important cause of death among young people. So, as I already explained, before puberty, depressive disorders are about equally common in boys and girls, but in adolescents, this ratio is changing. And the male-female ratio is 1 to 2, so twice as much mood disorders in females compared to boys. And of course, how to explain this? This could be one of the hypotheses that hormonal changes are one of the reasons that these differences occur. So regarding the etiology of mood disorders, it has a very multifactorial origin. And a very interesting model is the diathesis stress model, in which you can see that the combination of vulnerability and stress makes that some people do develop depressive symptoms and some don't. And the vulnerability can be explained by genetic factors, biological factors, but also psychological factors like cognitive styles, but also emotion regulation difficulties, but also, of course, environmental factors like trauma. And I think that's really important because then we can also understand with this model why some adolescents develop depression after stressful life events or other stressors, while others not. And why it's also so interesting to see that this very early adversity increases the later risk on depression, and why prevention efforts should be targeted both these vulnerabilities, but also the stressors already early in life. So let's look at these risk and resilience factors. What we know is that adolescence and young adulthood is this period of increased risk. So this can be seen as a risky period. The peak onset of the first episodes of a major depressive disorder is between 15 and 19 years of age. So it's something that in child and adolescent psychiatry is often a very focus of treatment and of diagnostic workup. What we also know is that mood disorders have a very genetic predisposition. And in twin studies, it is seen that the concordance is about 40 to 60%, with 40 to 80% in variance. And environmental stresses like family conflict or trauma do increase this risk. One of the main risk factors is having a parent with a mood disorder, because what we see is that the offspring have 3 to 5 times as much risk of developing a mood disorder like their parents. What we also see is that anxiety, ADHD, and for instance, substance misuse do occur as a comorbidity in 40 to 70% of the cases. So in most children and adolescents with a mood disorder, there's also a comorbid other psychiatric problem. And this complicates not only the diagnosis, but also the prognosis. And also what we know is that if you have a high level of comorbidity, there is a higher risk for recurrent episodes, which also raises the suicide risk. So one of the protective and preventive factors that we should take into account is having a supportive family, learning adolescents adaptive coping strategies and styles, which because these can reduce risk. And another important topic is that we screen early so that we can also offer early interventions in time in the case that there still are mild problems, and we treat these mild problems. So in order to be able to diagnose major mood disorders, it is important that we really know what we're talking about. What is the difference between mood, between affect, and between also normal mood fluctuations, especially in adolescence? So what we know is that mood is more like a sustained emotional state, which lasts hours to days, while the affect is something of a momentary emotional expression, which is often observed in the facial expression. We know that normal mood also varies. It varies with life events, but it rarely impairs functioning. While pathological mood, depressed mood, is more persistent, severe, and very disruptive to daily life. Depression also includes sadness, irritability, anhedonia, fatigue, and lack of energy. But it does present in different ways. And it also has to do with the age and the developmental stages of the child and the adolescence. And often other symptoms which are not related to mood, like sleep disturbances and cognitive difficulties, do occur also during depression. What is really important is that mood expressions can vary by culture and by age. And I think it's important that we make the distinction between the children at a school age and adolescents and young adults, but also take these cultural aspects into consideration. So with this slide, I would like to illustrate the dimensions of mood. In purple, you see depression in very different stages of severity. In the middle, you see the euthymia, the normal mood. And then we go on into hypomania with expressions of more energy and higher levels of euphoria, going into mania. If we look at this, we can see that unipolar depression is focusing on the depressive mood, Bipolar 2 is depression including hypomania, while bipolar 1 disorder is mania combined with unipolar depression. Then we have also the dysthymia. Dysthymia is more the mild mood symptoms, which have a very long lasting, and but they are not combined with severe depressive symptoms. And cyclothymia are the mood swings that are not fulfilling criteria of hypomania or depression. So this means that if you look at mood disorder classification from the DSM-5, we have several categories of mood disorders, and here is a summarization of their key features. So we have major depressive disorder, which is linked to persistent low mood, irritability, anhedonia, and also cognitive and somatic symptoms. Then we have the persistent depressive disorder, which is more like a chronic form, which lasts more than 1 year, which is different from in adults, where the duration should be more than 2 years. Then we have the premenstrual dysphoric disorder, which has a cyclic character with mood symptoms linked to menstrual cycle. The disruptive mood dysregulation disorder, which is a new disorder first mentioned in the DSM-5 and is one of the disorders that is looking at severe recurrent tempo outbursts, which has a very chronic course of symptoms. And this is very important to differentiate from the pediatric bipolar disorder, which we will talk about later on. Then, of course, substance-induced depression, or a depression that is linked towards substance use or medical illness. And then we have bipolar 1 or bipolar 2 disorder, as I explained, with the differentiation between hypomania and mania, and which is illustrated with episodes of depression and episodes of this mania or hypomania. So in this slide, you can see the DSM-5 criteria. I'm not going to read them all loud, but what is important is that it has 9 symptoms, and 5 of these symptoms must be present during the same 2-week period. But also, and that's really important, there is a clinically significant distress or impairment, which is linked towards these symptoms. Also, what is important is that if we have a diagnosis of depression, it's important that we see whether this is a mild, a moderate, or a severe form of depression. And it has to do with the number of symptoms that are present. But this classification of severity is important because it's related to the treatment plan that is linked towards these severity of depressive symptoms. So as you can see, it has to do with loss of interest, what we call anhedonia, but also depression impacts weight, it impacts sleep, but also it has to do with feelings of guilt, cognitive decline regarding concentration, of indecisiveness, and of course suicidal ideation or recurrent thoughts of death. So if we look at the clinical presentation of mood disorders in children and adolescents, it is important that these symptoms differ by age. And I will show you some differences between the school age population and the adolescent age population. But what is important is that irritability is also a main symptom of mood disorders in children and adolescents and is often overseen. Also, functional impairment and mood reactivity is important to consider, because the academic decline as a result of mood disorder is often overseen, including the fact that there is mood reactivity present, and this may mask the severity during positive events of those affected with a mood disorder. Of course, there are also subtypes, with atypical depression being some of the subtypes that is often not diagnosed correctly, because it has a very high level of comorbidity with anxiety, ADHD, and behavior disorder. And for this, it's not that easy to diagnose and have a comprehensive evaluation of mood disorder problems is really important. And therefore, we need multi-informant reports. So we need not only the child, but also the parent, the teacher. We need observations. And if possible, we also need rating skills from validated instruments for accurate diagnosis and also treatment planning. What is important is that if you diagnose a major mood disorder already in a young child, you see that the probability of recurrence, so a recurrent episode later during adolescence or young adulthood, is very high. So you see those having at a very young age already a depression. Most of these children do have a recurrent episode later in life. So that's a big risk factor. So now we focus on the characteristics of depression in children at the primary school age. And in this age group, you see that they are not able to actually name their depressive feelings. So what you can see is that they change in behavior. So you have a child which is typically developing, and then there's a change, there's a different behavior. And this behavior is showing that there is sadness, a lot of crying. Could be that there's a lot of irritability, so a change in behavior, disobedience, but also an increase in fears, in insecurity, feelings of guilt. But what is also very often overseen that this is linked to a mood disorder is that there are somatic complaints. So children complain about a headache or tummy ache, their play is inhibited, and also we see a decline in academic performance because they're not able to learn that fast anymore. In very severe cases, we also see that the weight is decreasing, and there's also no growth anymore or stagnation of growth on the growth curve. Also, young children can have thoughts of that, so that's important that you also ask about these thoughts of that. So to summarize, which is really typical for depression in children at primary school age, is that there is a change in behavior. So if we go to the depression in adolescence, in this age group, you see that it's possible for adolescents to talk about their feelings, how they feel inside. They talk about that they feel very depressed, but they also still have mood swings. And as I explained earlier on, these mood swings and mood reactivity sometimes is also masking the underlying depression. Irritability, loss of interest is also, like in adults, very present. And we also see that especially the withdrawing and school anxiety, problems with concentration at school is very often a problem during adolescence. Another thing that is often overlooked is that adolescents who are depressed also often are involved in delinquency or antisocial behavior because of their irritability, which is so prominent. What we also see is that they start using alcohol or drugs or be sexually active. So What is typical in adolescents is that they are now naming their depressed mood, like in adults, but that the behavior and the irritability and the symptoms that are linked towards somatic complaints, but also their behavior are very different from adults with depression. So let's go on to the treatment principles of major depressive disorder. And in this slide, you can see that the severity is going up from step 1 to step 4. And it also is linked towards what the intervention plan would be. So step 1 would be if you see a child with mild depressive symptoms, would be psychoeducation, supportive management of the child and also of the parents, so that we decrease the stressors and improve coping strategies and support. So the second step, in case this would not be helpful enough, or in case there's a child presenting with mild problems, would be cognitive behavioral therapy or interpersonal therapy for those who are in the adolescent age, for those with a moderate level of depression. And you provide this kind of treatment for 3 months. If there's no improvement after 3 months, we need to re-evaluate the diagnosis. Do we oversee something? Is there a comorbidity present? Or is there still a very important stressor that is supporting the depressive feelings? After 3 months and re-evaluation of the diagnosis, there would be an indication to start medication. That would be an SSRI. So the SSRI and for children and adolescents, only fluoxetine is on label, would be the first choice of starting medication. And what we know is that if there's a very severe depression present, CBT is not possible at that time. So you start a medication, and at the time that it is possible to also start CBT, you combine it. This type of medication and also the treatment with CBT needs to have an effect that the depression is going into remission. And after remission, of course, there is the time for maintenance treatment and relapse prevention. And maintenance treatment should be at least 6 to 9 months in case it is the first episode of depression. Prevention planning also includes a relapse prevention plan, which is not only set up with the adolescent or the child, but also includes the parents and even friends, family, and teachers. So to dig into medication a little bit more, fluoxetine is the only SSRI that is registered for the treatment of moderate to severe depression in youth. As I said, after 6 to 8 weeks, if there's no effect, you can increase the dose because you start low and you go slow, but you increase the dose to a maximum of 40 milligrams or switch to another SSRI, which is of course off-label. What is important is that the suicidality might increase in the first weeks after you start medication. So close monitoring and also risk evaluation is needed and an essential part of the depression treatment. And as said, the maintenance treatment should be at last 6 to 9 months. But if there is already more than one depressive episode, the maintenance treatment is advised to last at least 1 to 2 years. And here we follow the adult guidelines. So now let's go on to the bipolar disorder. Bipolar disorder, as said, is a disorder in which we have depressive episodes, but also episodes of mania. So when we focus on the manic episodes, mania is an episode in which there is an abnormal, persistently elevated, expansive or irritable mood. It's not only euphoric, it could also be mixed with a lot of irritability and even also psychotic symptoms. The duration is a minimum of 7 days, or in case there is a need of hospitalization because of the severe symptoms. And of course, there should be always impairment. So activities of daily living should be impaired because of these symptoms of mania. Also, if you look at the manic episode, grandiosity, a lot of activity, but also what we see is typically in adolescents is that they do a lot of spending money. They're not sleeping anymore. They are online all the time. They are talking a lot. They have a flight of ideas and a lot of racing thoughts. And they have these enormous plans. They feel on top of the world, and they feel that they are untouchable. A hypomanic episode is a mild episode with a less longer duration. And also it could be that the impairment is less prominent. But of course, hypomania should be also noticed by people that know the patient very well, and especially friends, family, and teachers recognize that there's a change of mood. So what do we know about bipolar disorder regarding epidemiology? It has a prevalence worldwide of 1 to 2.5%. The male-female ratio is 50-50. And the mean onset is between 15 and 25 years old. It's a very severe mental illness. You can also see that in the suicide rates, lifetime deaths between 10 and 20%. And what is important is that bipolar disorder runs in the family. What we know, and I've been performing and conducting several bipolar offspring studies, is that if you have a first-degree relative, so a parent with bipolar disorder, that the offspring have an increased risk of 10 to 20% to develop bipolar disorder themselves, but also a higher risk for developing any mood disorder, including major depressive disorder. And again, also bipolar disorder has a major genetic component, which is also seen in the concordance in monozygotic twin studies. A few years ago, Anna van Meter performed a meta-analysis on 17 studies which focus on the pediatric bipolar disorder, so in children between 7 and 21 years. And here also it was confirmed that the bipolar spectrum disorder, so that would be bipolar 1, bipolar 2, but also the mild version, bipolar disorder not otherwise subscribed, and cyclothymia, is about 2%, while the more severe form, the bipolar 1, is about 1.5%. And what is important is that pediatric bipolar disorder is not that easy to diagnose. It's not that common, and it requires a change in mood and behavior, which is not typical for the individual. It's much more extreme than is developmental appropriate, and it presents long enough to meet the duration criteria with a marked impact on functioning. And I think that's really important to keep in mind, because what we saw in the 1990s and the early 2000s is that there was an enormous increase of diagnosed bipolar disorder in children and adolescents. And this was also the reason that we had to evaluate the fact that bipolar disorder is a cyclic disorder, so that you have episodes. And as a result of studies in children that had been diagnosed with bipolar disorder during the lifespan, we saw that in follow-up, these children did not develop classical bipolar disorder once they were adults, but did show much more major depressive disorders or ADHD symptoms. And the disruptive mood dysregulation disorder is much more a diagnosis for this chronic irritability in children at a young age. So here you can see a figure that my colleague, Professor Kupka, and I already designed in 2012, because it gave us an overview of the staging concepts of bipolar disorder. And let me walk you through. If you can see, stage 0 is the at-risk stage. And this is the population that has a familial risk for bipolar disorder. Then you have the prodromal stage, in which there are already symptoms of mood dysregulation. In stage 1, B, and C, you already have depressive episodes in the context of a high familial risk for bipolar disorder. And then we say, of course, there's a unipolar depression. But once there is already an hypomanic or mania episode, then in hindsight, you can say that the diagnosis bipolar disorder has already an age of onset much earlier. Once you have more than 2 episodes of mania or depression, we can talk about recurrent bipolar disorder. And in stage 4, you can talk about a chronic bipolar disorder once there is much more inter-episodic impairment and there is a cycling of episodes, which is not often the case that people go on to this stage 4, but it is important that we also consider that in some patients it's very difficult to stabilize mood. So what is the age of onset of bipolar disorder? And I think this is really important, is that we can see that there are 3 ages of onset. The early onset with a mean age of 17, the mid onset around the age of 25, 26, and a late onset after the 40 years of age. And since the early onset with a mean age around 17 is the most prominent, this is why it's important that also in the child and adolescent psychiatry, we recognize this, this disorder. So what we know is that 45% of the patients with bipolar disorder have this early age of onset. And it's difficult to recognize because when you're 17, it's very typical that you show some risky behavior. And it's also typical that you have mood swings. And that's why it's often not recognized as part of a bipolar disorder. And that there is a diagnostic delay that is often 6 to 8 years before the diagnosis of bipolar disorder is established, which has, of course, a lot of impact on young people's life because they have lots of problems with finishing school, with social interaction, with friends and families, and in building their life. So what we know is that there are several risk factors, as said, having a familial load, but also already if you have recurrent depressive episodes, if there are psychotic symptoms in the depression, and if you have been treated with an antidepressant and experience disinhibition after the start of your antidepressive treatment, that could also be an early sign of hypomania and a vulnerability for bipolar disorder. But as said, the greatest risk is the undertreatment, and as a result of that, a severe course. So let's go on to how do we diagnose bipolar disorder during adolescence. As said, the episodic course of symptoms is really important to recognize. If there is a non-episodic course, then you might consider that there is a diagnosis of oppositional disruptive behavior or ADHD, and it's more chronic with already present from an early age on. Or there could be a psychotic disorder. In a psychotic disorder, we often also see negative symptoms, which can be difficult to differentiate between depression and these negative symptoms that are present in psychotic disorders and the development of schizophrenia. Typically in schizophrenia, we already see a decline in functioning, which often precedes the psychotic symptoms, which is not the case in bipolar disorder. We see a lot of overachieving in adolescents and young adults with a bipolar disorder. They often overachieve at school, and which is really different from those who are in the process of the prodrome of schizophrenia or another psychotic disorder. I think it's really important that we have a differential diagnosis and look for process diagnostics in the months that we are following up these young people with mood disorders to see what kind of mood disorder that is actually present in these patients. Another option would be to really consider other topics on the differential evaluation. One of the main things that I see, and I see a lot of adolescents that also have personality problems or a pattern of impulsivity, which could be overlapping with bipolar 2 or bipolar 1. Of course, as said, the diagnosis of ADHD. Sometimes ADHD is not recognized at an early age, and adolescents come for the first time for diagnostic workup. And then we need to consider, is there really ADHD, or does it interfere with functioning and with other problems? And of course, as said, the more psychotic or schizoaffective disorder, in which we see that there is also mood disorder problems, but that the psychosis is more prominent in this patient. So there are several instruments, and I apologize for the fact that this is not in English but in Dutch, but I hope that you understand the instruments that I would like to focus on. Of course, we have screeners for adolescents below the age of 18 and 18 plus. In the 18 plus, you have the MDQ. Under the age of 18, you have the 7 up, 7 down, which is also a screener that could be very helpful in distinguishing children at high risk for bipolar disorder. You have the ACIBA questionnaires with the CBCL, which is also involved in a mania scale. If you look for an interview, psychiatric interview, you have the KIDDIE sets, which is a semi-structured interview, which is really helpful in diagnosing according to the DSM-5 of all the diagnostic syndromes, but also includes the mood episodes and mood disorders on a very structured way. And of course, we have some instruments that can help you in looking at the severity of the mood disorder. And one of the things that is really important, if you would like to do a follow-up and even also use it for your diagnostic workup, is the life chart method. Here I show you the life chart method. This is kind of a diaries in which you can illustrate the symptoms on a daily level with your patient, and it's also possible to do this together with the parents. And with this, you can see that you can have an overview of the episodes of mania, hypomania, and depression. And it gives insights to the patient, but also can be linked to the use of medication and the effect measurement of medication. One other option is to use this life chart method to link it with the menstrual cycle, but also with stressful life events. And combining all these elements gives you a good overview of the personal evaluation of mood symptoms episodes and environmental factors that are linked towards these mood symptoms. So what about the treatment in bipolar disorder? What is important is that lithium is a very important medication in the treatment of acute mania, but especially in maintenance treatment of bipolar disorder, and especially in youth. What we know is that bipolar disorder is often recognized after the age of 12 years. Pre-pubertal diagnosis of bipolar disorder is very rare. So I will focus the treatment session on adolescents and not on young children. So in acute mania, the first choice is an antipsychotic. And it's not very clear, according to several guidelines, that there is a preference for a type of antipsychotics. But the type of antipsychotics you choose is based on your own experience, but also on the side effect profile. For instance, if you have a boy of 15 who is very active, who is not at ease, who needs to be sedated, then I would advise to use olanzapine, because it has, of course, the side effects of sedation. Once you have started with the antipsychotics and it's possible to discuss long-term treatment, start also already with lithium. Lithium carbonate is the preference maintenance treatment for young people because it has the best spectrum of side effects in the long term, especially since antipsychotics have a lot of metabolic side effects in the long run, and we don't want that. Also, the sedation and drowsiness for the antipsychotics is something that is often not compatible with school performance. In the acute mania phase, you need to start with the antipsychotics and treat this for at least 12 weeks, but also include a rest program, reduce stimuli, and of course, focus on safety and structure. If we then go to the maintenance treatment of bipolar disorder, this is indicated after there are 2 episodes, or in case there's a severe manic episode with also psychotic features, hospitalization, or a very highly burdened family history. Maintenance treatment starts once there's stability for 8 weeks. And as said, lithium is the first choice. It is still possible to continue with the antipsychotics, but in a lower dose. And it is important also to focus on psychoeducation, preferably in a group with young people who have the same problems, and of course also include the parents. So lithium is on label for maintenance treatment in bipolar disorder from the age of 13. Dose it once a day. In the acute phase, you focus on blood levels of 0.8 to 1.2 millimole per liters, and you need to do blood drawings quite often. You start with twice a week, and then you continue once there's a stable level of lithium in the blood with once a month. And if there's a maintenance procedure and the stabilization is ongoing, you lower the dose of lithium to a dose in which you have the blood levels of lithium between 0.6 and 0.8. Young people tolerate lithium very well. They still have a very good kidney function and also clearance. And what we also see is that younger people often have higher doses needed of lithium because that is necessary to become in the therapeutic latitude. Of course, lithium is a salt, and you need to be aware that with sports, with holidays in countries with a very high temperature, that you need to be taking water and salt enough so that you're not holding the lithium and get a lithium intoxication, which is present if the lithium is going beyond 1.5 millipore per liters, and then you have all these symptoms of vomiting, diarrhea, a drunken speech and gait, and which is quite something that you need to monitor and treat, of course. Other options for mood stabilization in the maintenance phase are lamotrigine, valproate acid, and carbamazepine. But valproate acid is not recommended in girls. Also, based on the latest literature, also not in boys because of link towards problems with fertility, and in girls with polycystic ovarian syndrome. What about the medication in bipolar depression? Primary, it is non-medical, so we focus on psychological interventions. In case in the bipolar disorder, depressive episode, there is a need for medication. You focus on optimization of the mood stabilizer, in most cases lithium. You check adherence, and otherwise you can add quetiapine or olanzapine in combination with fluoxetine, the SSRI. What is important is that you avoid monotherapy with an SSRI, because then you can induce mania. And that's also the case if you have a child with depressive episodes, but a high load of in the family of bipolar disorder. Monotherapy with an SSRI is advised to be avoided. So, of course, there are psychological intervention, as said, psychoeducation for young people, but also complete your treatment plan with a signaling plan. So what's going on before you get manic? What are the first symptoms of dysregulation? The lifestyle regarding a sleep pattern, but also a plan for alcohol and drug use, for involving peers. How do I tell my my friends and family what is going on with me? How do I consider stigma and sharing my experiences when I was manic and did something stupid and feel very guilty? Of course, there are some general health advices, and in some cases it can be very helpful to include individual therapy, but also family-focused therapy to support not only the bipolar patient, but also the siblings and the parents. And of course, we need to consider a cognitive decline after an acute phase of mania or depression, and consider that it takes months before they recover, also regarding school performance, and a neuropsychological examination can be very helpful in these cases. So, of course, somatic evaluation is important because of the side effects like skin problems with lithium, weight gain, but also kidney and thyroid function. And of course, we need to consider that these young people are at the beginning of their treatment plan as with a severe mental illness. So to summarize, the medication advice for bipolar disorder: in acute mania, an antipsychotic. It's not, there's no preference for a type of antipsychotic, but look for the profile of your patient and the profile of the antipsychosis medication. In bipolar depression, you focus on stabilization and optimization of your mood stabilizer and include cognitive behavioral therapy. And in case there's a persistent depression, then you can include olanzapine in combination with fluoxetine. And of course, as said, the long-term maintenance treatment, preferably with lithium. Comorbidity is important, and I often get the question, what do we do with people that also have ADHD? So you first install the mood stabilizer, lithium or antipsychotics, and then you can add the stimulants. Don't do it in the other way, because with the stimulants you can actually start the mania symptoms before you treat the bipolar disorder. So early detection is important, especially in those at high risk. So be aware of the first depressive episodes. If you see a young person, even before the age of 12 with the depressive episodes, be aware that there's a high risk for also developing recurrent depressive episodes, but especially also bipolar disorder. It is important that we focus on functioning. Decline in function is really important, and that the early detection is important for the prognosis, because the earlier you start with treatment, the less episodes the adolescent will have, and that has an enormous impact on brain health and on the prognosis in the long run. We also see that in studies that we have performed in the Netherlands. This is a slide in which we show that we started in 1997 with a cohort of 140 children of parents with a bipolar disorder. And here you can see that over the years of 22-year follow-up, there was a change in the development of problems. We started with about half of the participants that didn't have any psychopathology, and at the mean age of 38 we saw that 14% developed a bipolar disorder, but about 1/3 had a severe mood disorder, severe major depressive disorder, and in general 70% had a lifetime psychiatric disorder. So this is really a high-risk population. So be aware and always ask whether there is parental psychopathology in case you see a child. So in the early courses, we see that it's generally starts with anxiety symptoms at an early age, with depressive symptoms around 12 years old. Then around 14 years old, you have the first mild depressive episode. And then around 17, you see the first manic symptoms. And then you see an episode of mania between 18 and 20 years old. So this is the typical development of adolescents that have a high risk because of a family load of bipolar disorder. We are also very active in the International Society of Bipolar Disorder Task Force. And if you are interested in learning more, I could really recommend looking into these papers. So let me end by summarizing some of the findings and the important messages for bipolar disorder. The precursors of bipolar development and normal adolescence are very difficult to distinguish, but it is very important to diagnose at an early stage and monitor those who are at risk. Have an eye for these risk factors and also for those children with a high familial load. Do some process diagnostics with the life chart as I illustrated, and ask the parents, the teachers, and the people around this child if they see any mood swings and what are the essential symptoms of mania. For bipolar disorder, the episodic course and the energy is the core symptoms, which are very prominent and important to consider. The antipsychotic in the acute phase is the first choice, but taper them after 3 months because of the side effects and the metabolic symptoms that children and adolescents develop in later stages. And of course, as said, lithium is the first choice for the maintenance treatment. So I hope that I have given you an overview of mood disorders and also shared with you the importance of prevention because the prognosis will be better. So regarding prevention strategies, this early identification is important. cognitive behavioral techniques to improve coping strategies, active coping strategies and problem solving, identify high-risk group, but also consider e-health tools that might be helpful in psychoeducation, and in which also in Ukraine, it could be possible that we help you from other countries to provide these e-health tools. And of course, early onset and comorbidity are important as a risk factors because we know they worsen prognosis. And we need to monitor and support these families to improve long-term outcomes. And with this, I would like to thank you for your attention. And of course, I'm very open for any questions.
Ще раз всім дякуємо, хто до нас доєднався. І багато в нас запитань. Зараз я буду їх зачитувати. І перекладачі будуть нам їх перекладати. Зараз хвильку, їх дуже багато, тому я йду на самий початок. Зараз. Так.
Do I keep sharing my slides or can I stop sharing?
You can stop sharing.
Okay.
Так. Зараз. Так, питаю, чи можна буде повторно переглянути. Так, можна буде і на українській, і українську, і англійську версію в YouTube-каналі доктор Булавінова. І починаються питання. Пані Жанна Руднєва питає, як заспокоїти дитину після обстрілів, які знайти правильні слова?
So, the right words to use for to talk to the child, is that the question?
Mm-hmm.
To calm down. Sorry, I didn't understand quite. Well, that's of course a very important but also difficult question. I think it's important. Shall I continue? So it's important that we, of course, are honest to children, but that we also use words to ease them down, because it is important that children know and they react to our own fears, and that's often non-verbal. So if you use language which is really reassuring while you're also anxious yourself, a child is very sensitive to these messages. So I would say share with them that you also feel afraid, and share with them that this is a temporary situation and that you will always support this child, but that you are together in this situation, that the child is always that you are always available to discuss the fears with the child, and that you will look for a solution together. I think that would be my advice.
Пані Олена Грузін питає, дайте, будь ласка, методики для ранньої діагностики розладів.
Methodology. Yeah. So what is important is that the methodology for the early diagnostics would be that you first do a kind of evaluation of the risk. Is there a risk profile present in the child? So that could be taking the developmental overview of a child already starting from very early on. Did the child already have a good start? How was the pregnancy? Was the mother healthy? Were there any mental health issues in the family? Is the development typical, or are there already anxiety symptoms in a very early stage of school? What are the symptoms, and are the children in need of any psychological help already early on. So I would take the anamnesis very detailed, and also support the parents to see if they are in need of any support to help the child during the developmental stages. And of course, if you have screening instruments, it could be possible to see if the child is having problems that are typical for that stage of development, or whether you need to look for support and evaluation to see for diagnostic evaluation.
Пані Олена Снісарівська питає, які є нові ключові параметри диференціальної діагностики щодо циклотимії?
For cyclothymia, there are, to my knowledge, there's no new evidence. What we know is that for cyclothymia, it is important that we rule out that there was depressive episodes, and that we rule out that that there's no hypomania or mania. What we also see is that in adolescence, emotion regulation problems are very often prominent, and that is very typical for adolescents. So cyclothymia also needs to have an impairment in functioning. Otherwise, we don't call it cyclothymia. Then it's typical emotion regulation problems that could be part of the development of the identity or the beginning of an personality disorder.
Пані Наталія Назарчук, скажіть, які саме валідовані методики можна використовувати для виявлення депресії у підлітків?
The validated so I would say, as I presented, we have the DSM-5 criteria. So that would mean that you interview the patient. You interview also one of the parents, and if possible, you also have information from a teacher or somebody else who knows the patient very well. And then you look for the criteria. Are there symptoms of depression that fulfill DSM-5 criteria? And of course, there are also a lot of questionnaires like the CDI, like the CBCL, like what I showed you, that can help you support your interview and outcome of the interview. But in the end, it's the professional that has the interview with the patient and the child psychiatric evaluation that is clinically relevant.
Пані Майя Люсієв питає, чи характерне для депресії саме у дітей раннє прокидання? Які саме симптоми розладів сну характерні у дітей з розладами настрою?
So if you have a child that normally before the onset of mood problems had a pattern of normal sleep, you often see that there's a lot of rumination. So children are starting to ruminate and to have these thoughts, and that affects the possibility to start sleep. So they have sleeping problems falling asleep, but it could also be that they awake in the middle of the night or very early in the morning, and it's not possible to go back to sleep. So it could be both ways. It could be problems with falling into sleep, but also with sleep problems in the middle of the night. During an atypical depression, children sleep a lot. They sleep too much. So they feel that they are changing the day and night rhythm. So they don't sleep in the night, but they do sleep during the day. They take little naps, or they hide and have a social withdrawn pattern in which they only want to lay in bed, but it's not possible for them to actually sleep.
Пані Світлана Бокова питає: діти прикордоння молодшого і середнього шкільного віку постійно в напрузі. Які методики чи літературу порадити для зменшення стресу?
Yeah, so I can only imagine in the circumstances that the children in Ukraine are actually now need to live, and that is really difficult to differentiate these stressful circumstances and the stress that it causes in these children from depression. I think I feel that for me it's not really possible to help you in differentiating these symptoms from the acute stress that the children have because of the circumstances as set by bombing of continuous threat. But if that's not the case, and there is this level of stress which affects not only their sleep, but also somatic complaints, their fatigue. It is possible because normally the children didn't have these symptoms. So it really is about the change and the occurrence of these symptoms that lead you to be aware that there could be a depression. And in the school-age children, it is so difficult because they don't have the language yet to tell you how they feel inside. So it's not possible. If you ask them how do you feel, they cannot tell you that they feel depressed. They can only tell you what they feel in their body, and they show you with their behavior. So the behavior will be different from that you used to know. So it's important that you follow the information from the parents, and sometimes it's important that you do this play activities. And with the play activities, you can see that the child is relaxing, or what is the cause of the stress that is ongoing. So we use play activities in the evaluation of depression in children, but also in supporting and in treatment.
Так, всі тут дякують перекладачам. Пані Олена Снісаревська пише: додам, бо зазвичай кожен раз відкладаю і забуваю. Велика вдячність нашим перекладачам, ви кращі. І пані Фіалкора Міндру: велика вдячність перекладачам, ви неймовірні. Ми також дякуємо нашим перекладачам, дуже вас любимо і знаємо, що вам з нами непросто. Так, пані Тетяна Голосова питає: якщо хлопчик має різкі перепади настрою, йому 7 років, під час уроків він інколи розмовляє з уявними друзями, йому важко опановувати шкільну програму. На вашу думку, чи є це початком біполярного розладу?
Yeah, so normally we don't see bipolar onset before the age of 12. So in case a child of 7, as I recall you saying, has imaginary friends, this is more like a child that is using his own fantasy to retract from reality. And maybe it could be that there is a stressor in school or in the family, and of course, which is now ongoing in Ukraine, can be very stressful. But I wouldn't say that this would be the beginning of a bipolar disorder. You also mentioned mood swings. I think the mood swings could be also present in case there is a developmental disorder. As said, so I would broaden my diagnostic overview and look for the change in behavior. Was there a real moment in time that it changed? Is there something going on with the sleep? What is ongoing in the family situation? But again, bipolar disorder often starts after the age of 12. The first episode is in more than 80% a depressive episode, and in the school age, you mostly see anxiety and not the mood swings already.
Пані Тетяна Мавровська питає, що є ключовою диференційною діагностичною ознакою між афективними розладами та розладами поведінки в дитячому і підлітковому віці?
Between affective disorder and behavioral disorder. Yeah. So affective disorder is focusing on mood and anxiety, while behavioral disorder is focusing more on the behavior, as the word already says. But it could be that the behavior is actually a symptom of underlying mood and anxiety problems. So if you see a behavioral problem, it is important to distinguish this from a developmental disorder. Is there already from early age on a problem in behavior? Would there be oppositional behavior present? Is there ADHD present? Is there maybe an autism spectrum disorder ongoing? So something that already started very early on in life. And regarding affective disorders, you mostly see this ongoing at the end of the school age, around 9-10 years old, or during adolescence. And it's not that typical to develop already affective disorder very early on in age, while behavioral problems do.
Пані Анна Волкова питає, якщо батько має біполярний розлад, мати має рдуг. В дитини хлопчик 10 років, діагностовано рдуг. Яка вирогідність, що додатково розвіється біполярний розлад? На що треба звертати увагу? Як при рдуг побачити манію?
Yeah, so it depends how old the child is, but
10 років.
10 years old. Okay, so I would normally see this child in follow-up. I would advise you to be aware of possible mood problems, especially first depressive symptoms. I would also look for the effectivity of the treatment of ADHD. I don't know whether this child is using stimulants, but if the child is using stimulants, is this still needed also at the age of 13 or 14? And I would discuss that this child is at risk for developing bipolar disorder like his father, but it also depends on what age the father developed his own bipolar problems. And if the father was treated with medication that is really effective, I would also consider this medication in case the child would also develop mood problems. So in case the father is using lithium and is a very good lithium responder, and this child with an ADHD diagnosis would develop a depressive episode, using stimulants, I would consider also doing a follow-up of this child, and in case there are hypomanic symptoms, already start early on with lithium, in case the father is a good lithium responder. So it's a high risk and you should monitor this child, but 80% does not develop bipolar disorder, but 10 to 20% does.
Пані Наталі Маслакова питає, які рекомендації існують для зменшення вирогідності розвитку біполярного розладу у дітей, якщо це було у батьків?
So if the parents have bipolar disorder, if there's one parent or there are two parents, then my recommendation would that that the adult psychiatrist, who is the treating physician of the parents, talks about the risk for their children, and what you can do is do something regarding prevention. Is that you discuss the risk and adjust the lifestyle, focus on early symptoms like anxiety, depressive symptoms, focus on regulation of sleep, tell the children that they don't experiment during adolescence with alcohol and drugs, and that is what you can do. And in case the parents feel that there are mild problems, treat the mild problems. Don't wait, but treat the mild problems with not with medication, but with psychological interventions, and offer active coping strategies.
Пані Наталі Маслакова питає, яка причина виникнення біполярного розладу?
What is the reason? Well, what we know is that it's a very heritable condition. So there's a lot of genetic involvement, but we also see that it's an interaction between the genes and the environment. In many of the patients that develop bipolar disorder, we see that the first episode is triggered by stressful life events. These stressful life events often have to do with loss or with a change. That could be a change because there is a change in because they are moving, or there's a change because they are starting a new education, or because of a jet lag, because there is a change in sleep pattern, or there are stressful events because of a breakup in a relationship. And you have this genetic vulnerability, and the combination with the stressful events could trigger the first episodes of bipolar disorder.
Так, зараз хвильку. Пан Вадим Ульянов питає, поділіться, будь ласка, вашим досвідом контролю і управління суїцидальною поведінкою підлітків при депресії.
Yeah, well, I think we can give another lecture on how to manage suicidal behavior in adolescence. But it is important that we ask about suicidal behavior. Often professionals, but also friends and families, are very hesitant to ask the question, do you feel that you don't want to live anymore? Do you have these thoughts about that? Are you thinking about hurting yourself? And often it is thought that if you ask about it, that you bring this topic into the mind of these children and adolescents. But it's often a relief that you ask about it, and that people share their anxieties and their thoughts. So my first advice is ask about it, and keep asking, and also make a plan to keep children safe. And one of the things to keep them safe is discuss it openly, and ask about the detailed question about the level of plans that they have. Do you have medication in-house? Do you have a knife? Do you have a rope? What is the plan? Do you have a date? Ask all these questions. And if you have more information, then you can make a plan. What alternatives are there? Can you confide in somebody? Is there somebody who you would tell that you feel this way and ask for help? And in what way do you like to ask for help? Are you calling somebody? Are you asking somebody? Are you texting somebody? and make a plan what you can do in case the suicidal thoughts are so strong that you can't resist anymore. That would be my advice in the short question and Q&A.
Багато людей просять прислати лінки на тести та опитувальники для дітей та підлітків, для діагностики дітей та підлітків. І наразі ми переходимо до останнього запитання, бо в нас вже 20:28, від пана Прокопова Володимира. Коли ми говоримо про ранній вік до 3 років, дітей, які мають особливі освітні потреби, яких об'єднують страхи вибухів та несформована мова, які, на ваш погляд, краще використовувати діагностики, які могли б вказати, з чого починати, щоб не навантажувати маленьку дитину великою масою тестів?
Yeah, so if I understand the question is, what can you do with children, with very young children under the age of 3 that are not that are having special needs and cannot tell you what is ongoing? Is that the question?
Mm-hmm.
Okay. So again, it's not a very easy question, but I think what is important is that the behavior these children show you is the best thing that you have. What we know is that changes, for instance, in sleep pattern, but also if the child is already continent for urine and for going to the toilet, and that has changed, that they are wetting the bed again, they are all signs of increased stress, but also that they feel that they don't want to let you go, that they are very stuck to their father or mother or other important persons. This is also something that, of course, indicates a lot of fear. But of course, it is already very difficult to diagnose children of this young age when they have also special needs, if there's not a situation like which is now ongoing in your country with a continuous threat. So I'm not a specialist in infant mental health. I think it would be wise that if you have specific questions on this domain, that I refer you to colleagues with more knowledge on this topic.
Ми дуже дякуємо. Нагадуємо всім, що ви були в нас на серії з нашої регулярної серії з ЕСКАП, з Європейською асоціацією дитячої та підліткової психіатрії, яку нам допомагає організовувати професор Йорг Фегер, за що ми йому дуже-дуже вдячні, в якій погодились приймати участь лідуючі професори країн Європейського Союзу, і вони це роблять в свій неробочий час і роблять це про-боно. І ми дуже дякуємо сьогоднішній нашій спікерці Манон Хіллергерс, професорці дитячої та підліткової психіатрії, керівниці відділення дитячої та підліткової психіатрії і психології Erasmus MC Роттердам, Нідерланди. Манон, ми вам дуже-дуже дякуємо. В нас в Україні сьогодні дуже холодно і дуже темно, бо в нас, як ви знаєте, є атаки на енергетичну систему. Але, незважаючи на це, нас було більше, ніж 400 людей в цьому ефірі. І ми дуже дякуємо всім, хто, незважаючи на авіаційні атаки з неба і на те, що темно і холодно, все ж таки цікавляться цією темою і приходять на ці ефіри. Всім бажаємо тихої ночі. Манон, ще раз дуже вам дякуємо за вашу увагу до України і до наших спеціалістів.
Well, thank you very much to all of you for listening to my presentation. And I wish you a lot of courage and a lot of love from the Netherlands. And please let me know if I can be of any help. So thank you very much, and keep up the good spirit and care for children and adolescents in these difficult times.
Дякуємо всім, дякуємо перекладачі.